Hello, Sports Medicine. This is Chapter 17. Objectives. Upon the completion of this chapter, you'll be able to describe the anatomy of the foot and ankle and lower leg, primary extrinsic, intrinsic muscles, common injuries, and conditions affecting the foot, ankle, and lower leg, and describing medial tibial stress syndrome and its treatment. This is where the rubber meets the road. The previous 16 chapters have prepared you, your foundation in the evaluation process. So now that we're at a specific joint or a specific anatomical location in the body, we're going to be applying all of those skills that you've covered up to this point. Someone walks in and they're complaining of a lower extremity injury. Right away, you should be thinking what? If you said history, you're on track. So history, observation, palpation, special tests, that's basically what your evaluation procedures will be. History starts with present history and then also includes past history. Some good present history questions. You're trying to identify the mechanism of injury. The stress applied to the tissue. Was it a traction force or was it a compression force? So in order to get to that information, you need to know what happened. How did it happen? When did it happen? Were they the only person involved? Were there other structures? Did they step on something? 27,000 ankle injuries happen every day. And so in order to figure out what's going on for this particular injury, again, you've got to get that mechanism through what the patient tells you, that information that they share with you in the history process. Don't forget, you also need the past history. So was there any surgery in the past? Were there any lower extremity injuries that put them on crutches? Had they had x-rays? Important information as we go through this chapter. Next step is observation. And so as we go through the rest of chapter 17, I'll point out some important observation concerns as well. Chapter 17, lower leg, some common injuries based on the fact that the lower extremity is exposed to numerous types of trauma, contusions, and compartment syndromes. Compartment syndromes are really bad contusions in the lower extremity. From the knee to the ankle, all of those structures are held together in tightly wrapped compartments, and a contusion or bleeding in that compartment can start to cause some really bad problems. Sprains, which deal with ligaments, bone attached to other bones, strains, which involve muscles, and tendons and the musculotendinous junction, tendinopathy, the new term we refer to instead of tendinitis, which could lead to tendon ruptures, medial tibial stress syndrome, as we mentioned in the objectives, and stress fractures and other fracture types. So the textbook does go through a really nice supply of the bony anatomy. Foot and ankle injuries generally occur based on the mechanics involved in the foot and ankle. Ground reaction forces have a lot of impact or a lot of influence on the type of injuries that you'll see. 15% of sport injuries involve ankles, ligaments, bones, and tendons. So again, kind of back to that number, 45% of all basketball injuries involve the foot and ankle, lower leg. 31% of all soccer injuries involve foot, ankle, and lower leg. And then 24% of volleyball injuries. So it's critical that your observation skills are keen. So as you take a look at these illustrations, the one on your right is really pretty easy to see because you can see the soft tissue as well as the bones. That illustration is showing a left ankle in an inversion position, common to the inversion ankle sprain. But the illustrations on the left, the medial view and lateral view of the ankle, right away you've got to know which one is a right ankle and which one is a left ankle. These two are both, if you said right ankle, you're correct. The medial view is showing the great toe with to the left with the calcaneus all the way to the right. A great feature to obviously be looking for is the tibia. Whichever side the tibia is on, that's always going to be your medial anatomy. And then in the lateral view, the fibula is most present in front of that illustration, again showing a right ankle. The nice thing about these illustrations, they show the ligaments above on the medial ankle. That deltoid ligament is a very broad band of ligamentous structure with a lot of overlap. So it's a very strong ligament, holds the medial side of the ankle in place with some great efficiency. Look at the lateral view below, and those ligaments are very slender with attachments just specific to each ligament involved. Obviously, the anterior talofibular ligament, shown here, attaches the fibula to the talus in the anterior portion of the distal end of the fibula. The ATF, anterior fibular ligament, that's the most common ligament sprain you're going to see in sports medicine. Again, ankle sprains come in the three levels. We talked about this earlier. Based on the amount of damage to the tissue, first degree, second degree, third degree. First degree is the most mild, third degree is most severe. Ecchymosis is always a good indicator, especially if they've injured it, days ago. 3 days ago. The more ecchymosis that you'll see that starts to show up in the tissue based on the fact that it's had enough time to migrate towards the surface. So initially, you're not going to see ecchymosis right away. So you really wouldn't be able to see or understand how much of that tissue has been disrupted. Ecchymosis is a sign of bleeding in the tissue, so there was enough force, traction or compression, to tear the blood vessels associated with either the ligaments, the bones, or the muscles surrounding that area. Treatment for ankle sprains, we use Price, protection, ice, compression, and elevation. So the modalities, thermal agents, ice. The compression portion of it is very important, especially down at this region of the body. The textbook has those 3 degrees listed on page 351. First degree sprain, one or more of the supporting ligaments are stretched. There's minor discomfort, point tenderness, little or no swelling. Second degree sprain, a portion of one or more of the ligaments is torn. So enough force to tear the ligament is also enough force to tear the blood vessels, hence the fact that there's generally some ecchymosis involved in a second degree sprain. Point tenderness, disability, loss of function. There might be some abnormal movement of the joint, and you might find some laxity. A third degree sprain, one or more of the ligaments have been completely torn. And so third being most severe, it results in joint instability, extreme pain, or little pain. If the nerves have been damaged along with the ligamentous tissue, you're not going to have a whole lot of complaint of pain because that signal of pain is no longer being transferred. Loss of function, point tenderness, rapid swelling. In order to identify the degree, the illustration in the slide here is showing significant amount of ecchymosis on the lateral aspect of the lower extremity. This is quite common with tearing of blood vessels surrounding the anterior talofibular ligament from an inversion ankle sprain. So now we're going to move into the special tests involved in identifying whether or not there is some ligamentous laxity. Down here you can show the illustration showing the clinician's hand placement at the distal end of the lower extremity, holding on and supporting the lower extremity, while the other hand is used to draw the foot complex forward. When the anterior talofibular ligament is in place, there is some resistance to that foot being drawn forward. When the anterior talofibular ligament is not there, that laxity will start to show up and the foot will draw itself forward without any ligamentous support stopping it. And then again, you would use the uninvolved side to compare your findings. The talar tilt, another lateral ankle sprain evaluation special test. And so in order to show this to you in lab, we'll have hands-on, but in the videos illustration, I'm going to show you a quick illustration of that, or a quick video of that for lab.
Common tests of ankle injury. The anterior drawer test is used to test the anterior talofibular ligament. The anterior talofibular ligament is the weakest and the most commonly injured ligament in ankle sprain, which is called lateral collateral ligament injury. The talar tilt test is used to test the calcaneofibular ligament. It's probably testing the anterior talofibular ligament and the calcaneofibular ligament.
So, in our evaluative procedures, those two evaluative techniques will come in handy as we progress through the possible injury types in our evaluation. You have to rule out other structures that could be involved. So we'll move on to some other special tests. The Kliger test, which is also called the exterior rotation test. This is testing or putting a stress on the deltoid ligament. Again, the illustration here shows the clinician's hands, one stabilizing lower extremity, the other using the foot as a lever to put significant stress across the medial aspect where the tibia meets the talus, and that stress will be resisted by the deltoid ligament. If this position causes pain when the clinician applies that stress, if pain is increased, that's indicative of a deltoid ligament sprain. The Kliger test, the external rotation test, is also a way to test the syndesmosis, which is at the distal end of the tibiofemoral joints, or tibiofibular joint. So this structure here, the syndesmosis, holds these two bones together, and again, as this stress is applied, it stretches out the bottom portion of the leg syndesmosis. This is also known as a high ankle sprain.